right, let's get started. Good afternoon. I know we're in the final stretch, and I have not had any afternoon coffee because I couldn't find any, so I'm just going to pretend that I have had it and be very hyper. So you have had a great full day, and we're on that wind down, but we're going to keep things going right now, hopefully in a topic that we are all invested in, which is the legal and billing issues related to telehealth. And so my name is Kathy Riberly. I'm director of the Mid-Atlantic Telehealth Resource Center. I spend most of my time helping providers with all their questions about telehealth. And so I am joined today by two terrific panelists, Amanda Dennison with Blue & Company, who'll zero in on financial and operational realities of how billing and reimbursement changes impact FQHCs and RHCs in particular, and then Anna White's, attorney with Anna White's Law Office, will bring us up to speed on Kentucky-specific changes in laws and regulations, including what's happening with Kentucky Medicaid, which is always a big hot topic area. Together, we're going to try to unpack what's coming down the pike and what you need to know right now. And obviously, we cannot ignore the elephant in the room right now, which is the Medicare policy cliff, which you already heard a little bit about from Rob Sprang and from our previous keynote speaker, Dr. Scott. And so if you've been keeping up with the news, you also know that Senate negotiations pretty much came to a standstill. The failed vote, and so we are at a point where Congress has gone on recess with the cliff at the end of this month, which is next week. So bottom line is we are pretty much assured that government is going to shut down at the end of this month. And what that also means, as all those great telehealth waivers that came in during the pandemic, they will go away at the end of this month. So what we do know, the good news, is that the House continuing resolution had all of the telehealth waivers in it, and it passed pretty much unanimously through the House. There was no opposition toward the telehealth piece. So that's good news, because at whatever point it takes for Congress to reach a deal, we're pretty confident that all those telehealth waivers will be in that deal. The problem is not knowing when that deal is going to happen. The other thing that we are pretty confident about, obviously there's no guarantees, is that they will retroactively, when they reinstate the waivers, make that retroactive to when the shutdown happens. But again, there's no guarantees, so we can't say with 100% confidence of that. So I'm going to pose a crystal ball question to our ladies here. Given the history of government shutdowns in our country, how long do you think we're going to go before Congress acts again? Anna, what are your thoughts?
Well, I'm not going to give away. Amanda Googled this, and so she may have some answers I don't. I think it's definitely going to happen, and I think it's not going to end in a number of hours. This battle is so partisan, and both sides are so entrenched in fighting a war over various bills that it's going to take time. And I think we need to remember that telehealth is probably on nobody's radar. When I talk to congresspersons and say, what about the telehealth bill though? I get, what? Because we did our job too well. We made telehealth something that everyone is used to. If you are under 40, you've probably been using telehealth most of your working life. And so I don't think it's triggering with anybody that telehealth is one of the things on the chopping block when the waivers end. I joke and I said I got a really big bang for my buck when I said, do you know that ambulance reimbursement is also ending? And everyone was shocked. Whole room of Congress people. What? And I said, yeah, you know how much ambulance providers charge without the support. That made them think. So it just depends the angle that you approach it from. But my guess, if I'm going to guess, I'm going to say 2 weeks. but that is 100% a guess. I'm a lawyer, but I'm definitely not your lawyer. You haven't signed a contract with me, so take it all with a grain of salt.
Amanda, what do you think?
All right, so I do agree. Obviously, this is something that's going to happen. We were joking that pending the rapture happening, like it's going to go into effect. And when we looked up to see, sort of what's a typical government shutdown, the longest one that we've had historically was back in 2018, 2019, and it lasted 35 days, okay? So 35 days maybe for a large hospital to have to hold telehealth claims might not be such a big deal. But for small rural hospitals and independent rural health clinics that have a couple of providers, having to hold claims for telehealth for that long is going to be detrimental. Okay. So again, I'm not even going to pretend to know how long it's going to take. It also wouldn't shock me. We heard the number of November 21st floating around there when we were talking about, maybe some temporary extensions, right? The continuing resolution. It wouldn't shock me if they tried to hold out until November 21st, just so that they can throw a fit and act like, hey, we told you so. But again, there's really no way of knowing, but bottom line is it's going to happen regardless of whether it's a couple days or longer.
Right, so come October 1st, what does that mean? I'm going to do a really high-level rundown, and just know that there's a lot of nuances to this, so this is very high level. The location of the patient will matter again, okay? So pre-pandemic, the patient had to be in an eligible facility that was located in an rural and underserved area. So just rural if it's in a non-MSA, metropolitan service area, rural and underserved if it's in a metropolitan service area but considered rural. So it gets complicated.
Super clear.
Yeah, super clear. So without an extension, that means that your patient can't be sitting at home doing their telehealth visit, with a couple of exceptions. So a couple things have been made permanent, not perfect. Wish they were made perfect. So mental health and substance use treatment services, especially with co-occurring conditions, that was one of the exceptions. So you can continue to see those patients at home. End-stage renal dialysis services can continue in the patient's home without the geographic and facility restrictions. And acute stroke assessment and treatment can be done from the home or from any location. So those are the only exceptions that have been given to that rule. Otherwise, the patient needs to be in an eligible facility, and that eligible facility has to be in an eligible geographic location. Whew.
Could you reinforce Medicare?
This is just for Medicare now we're talking about. So don't freak out about everything else. All right, second impact, audio only will be significantly limited. Now, CMS actually did a really good thing this year, and they passed some changes in their rules, basically saying, yes, we will reimburse for audio only to the home. Okay, now think about what I just said. Since home is now restricted to those handful of services, audio only pretty much goes away because you can't see patients in their home. Now, if it gets reinstated or if home gets made permanent, then audio only actually gets made permanent as part of that. But CMS made the change basically saying audio only was allowed to the home as long as the provider was able to provide video and the patient either refused or was unable to do video. All right? So know that that is a permanent piece, but the to the home piece is now the limiting factor if the waivers go away. All right? Third big piece, provider type. Prior to the pandemic, I think one of the speakers talked about that, it might have been Rob, there was a list of eligible provider types who they said could provide telehealth services. And these provider types were MDs, mental health providers, ODs, nurse practitioners. They did not include PTs, OTs, and speech language therapists. So those were the people that are going to be seriously impacted if the waivers go away, because they are no longer eligible telehealth service providers for Medicare. All right, fourth is a new one. This was actually not pre-pandemic. During the pandemic, CMS instituted a new guideline about mental health services. And they said, if you are going to do telemental health to the patient in their home, you needed to have had an in-person, as in face-to-face in-person visit in the 6 months prior to initiating your telemental health service visit, and then every 12 months after that. So because there were no guidance documents provided, and then the pandemic issued a waiver for that, we have no idea right now what would happen October 1st. Will they count existing patients as, oh, the clock starts ticking now and you needed to have a visit 6 months prior, in which case probably none of them did? Will they grandfather them in and just say new telehealth encounters or telemental health encounters will have had that 6 month requirement? We don't know. What they said was that the in-person would have to be within that practice or practice group. We don't know what that definition is. Like if I'm University of Kentucky, is practice like anyone in the University of Kentucky physicians group, or is it just in my little practice with my 2-3 people? We don't know. So that's a huge unknown, and I am kind of shocked that there's been no guidance provided to this point, because we are very close to the cliff. So that's another piece. And then for any of you who are in large hospitals or health systems doing hospital at home, that was part of the waiver. And so that program will actually discontinue come October 1st. And so you would no longer be able to get reimbursement for patients who are receiving acute care at their home. Those are the big ones, and they're huge. So high level, again, there are some nuances, so make sure that if you have some nuanced situations, you ask those right questions. But one of those nuances has to do with FQHCs and RHCs. So Amanda, let's start with you on this one. When these Medicare flexibilities expire next week, what does that mean on the ground for FQHCs and RHCs?
Sure. So I think the biggest thing is going to be just the sheer fact that RHCs and FQHCs can no longer serve as a distant site for telehealth, right? So that was something that was only made as a temporary flexibility during COVID. And prior to that, we could only serve as the originating site, okay? That means that you can essentially host the patient in your RHC or FQHC, and they can see a provider who's physically distant elsewhere doing a telehealth service. That pays you about $26 a visit with Medicare, okay? That's not a whole lot. It takes up an exam room, it takes up resources to be able to do that. So that's one of the really big things that's going to change for RHCs and FQHCs. We talked about the mental health piece of this. That's still going to remain the same for RHCs, okay? That was something that was made permanent in 2022 to allow for mental health telehealth services to take place. Now, one really big stipulation that I want to make here is that a mental health telehealth service does not simply mean you are treating a patient with a mental health diagnosis, okay? So think about your patients who have depression and anxiety that you are doing a medication management visit for. That's a 99213 or 214, however you end up coding it, that's on you. But you're not going to be able to do those as a distant site service anymore because that's not a mental health service. It has to be one of the codes listed on your RHC or FQHC qualifying visit list, which again, if you're familiar with revenue codes and things of that nature, it's things that fall under a 900 revenue code, okay? So it's psychotherapy, psychoanalysis. It's not medication management. So now all of your patients who you see for mental health telehealth visits, if they need to do a medication management visit, they're gonna have to come into your clinic to do it, okay? There's probably lots of other nuances, but I'd say those are probably your really, really big ones. One thing I do want to clarify too is that for any of you who have read the 2026 Medicare Physician Fee Schedule Final Rule, there's some language in there about how G2025, which is the code that we use to bill for telehealth right now, right? About CMS extending that through the end of 2026 to allow for that payment. That's great. But if it doesn't fix the originating site issue for an RHC, cool, we can get paid for a service that we can't provide, okay? So again, I think a lot of us in the RHC and FQHC world have leaned a lot towards, oh, well, CMS has said we can do this. Sure, that's great, but they're not going to be paying you to do anything because you can't do it. Okay.
So there's a lot of confusion around that whole thing
Yes.
because the physician fee schedule, even for 2025, talks about the end
Correct.
of the year here. And we don't actually have definitive guidance from CMS on this issue. It's just two blurry, conflicting pieces of information.
Correct.
So
Par for the course.
take that for what it's worth. So in your view, what's the single most significant impact it's going to have for QHCs, and what should they be preparing for?
I think the very first thing I said, just the fact that you're really not going to be able to do telehealth services with your Medicare patients. And the biggest impact there is it's kind of a snowball effect for your patients, right? So these patients can't get seen via telehealth. So people are like, oh, it'll be fine. They'll just come into the office instead. Do you really think that a patient who has been primarily seen via telehealth for the last 5 years is all of a sudden going to be like, yeah, sure, I'm just going to drive into your office to get my care? No, they're just not going to seek care. And then they're going to have exacerbations of chronic conditions. And then they're going to end up in your ER. And it's going to continue to just be this vicious cycle over and over and over because they don't really care that it's an inconvenience for you. They're not sitting here looking at the policy. They're not worried about that. They're just worried about, well, how am I going to get my care? You can't do it via telehealth. I'll find somebody else who can. Sorry.
Not
to get on my soapbox or anything.
So Anna, how about you? In your view, what's the single most significant impact that this is going to have on the clients that you work with?
Well, I get to be a bearer of better news because most of my clients are either Medicaid or commercial plans, and they're not as impacted. It doesn't matter whether or not the Medicare piece passes or doesn't pass or is on hiatus. We still in Kentucky have Medicaid, and that Medicaid still covers telehealth services just as it has for years. With the exception, we did see in Kentucky, waivers ended, I should know this, months ago, and we had to start seeking prior auths. We had to see people in person if that was a requirement when the Kentucky State Medicaid waivers closed. But you can still do with Kentucky Medicaid the same telehealth that you have been doing, and we don't anticipate that changing in the next, this is a guess again, year or two. I've been attending the Medicaid Oversight Advisory Board meetings, and every time this question comes up, they become very opaque. We like telehealth. We know it's important. Yes, Anna, thank you for asking us that question. So I think Kentucky Medicaid is going to continue covering what it has, but is going to reserve judgment on whether changes are going to happen probably in the 2026 legislative session. So in January, I would look for some bills, some language about how it is going to change. In Kentucky, we like telehealth. It saves MCOs and the state a lot of money. I don't anticipate a Medicare-like problem. So for our Medicaid folks in Kentucky, I think the biggest challenge for you is going to be looking at a room full of patients and saying, you have to come into my office and see me. I'll see you Tuesday at noon. And you, oh, anytime, telehealth is fine. And I think for a lot of us as providers, it's very hard to say to a patient, I won't see you because Medicare won't cover it. And so I think we're going to have to be very financially, fiscally savvy, because I see a lot of providers already providing unreimbursed care. And so really think about, now is almost too late to look at your patient roster and say, in 5 days, what am I going to do with Susan? Start thinking about those hard questions.
Perfect segue. So we've been talking about what's going to happen. And now we're going to move into a little transition into, if you haven't started planning for this clip, you've missed the boat a little bit, but it's not too late. You have a week. So Amanda, let's hear from you again. After September 30th happens, Medicare no longer reimburses for all of these kinds of telehealth visits that we've been used to. from your standpoint, how might an FQHC or RHC assess the impact on their patients and and evaluate their financial risk?
Sure. So I'll kind of piggyback off of what Anna was talking about, about how your Medicaid and your commercial payers are going to be really unimpacted by this initially. So I think your first thing is you're going to have to look at your payer mix for your patients in general, right? In Kentucky, because of Medicaid expansion, we do have higher Medicaid volumes, right? So that is a good thing. But we do have some areas of Kentucky who have very large Medicare populations. And so you're going to have to look at your payer mix and say, okay, if I have a large base of Medicare patients, okay, I need to be working on my messaging to not just them, but my staff as a whole, right? I think a lot of times when there are changes that are made from like a policy or legal standpoint, maybe the office manager knows or something like that, but that doesn't get communicated down all the way through the providers and to the staff to know that, hey, this isn't something we can do right now. So working on your messaging now, I think is really important. Looking at your payer mix to know what patients are we still going to be able to provide telehealth to. So that you can at least stay afloat from that manner of things. But really just putting smart contingency plans in place and being able to clearly communicate that across all facets of your organization, I think is going to be really important. And the other thing, that I point out to people too is that efficiency equals time equals money, right? So anytime we have big changes like this, that interrupts our efficiencies, right? And because our efficiencies are interrupted, that's going to cost you money. So that's why having these contingency plans in place is really important, is so that you can continue as much as possible, business as usual, uninterrupted in terms of your care you're providing patients.
So let me see a show of hands. How many of you have already established a contingency plan for what happens October 1st? Show of hands. Not a lot of hands here.
You all are not very confident in your hand raising.
So either you're not very confident in raising your hands or you really don't have a plan. And if you don't have a plan, let me put to either of you, what do you think, what's the cost of waiting until October 1st?
It's never a good idea to wait. I am an oldest child and a list maker, so I have a plan for everything. But in terms of your practice, your business, even if you see primarily just Medicaid, it is time to start thinking about what I would do if telehealth is taken away. If you're seeing Medicare patients, you need to promptly, I hate to be an alarmist, but you need to go home. And it's going to be a long weekend for you. You need to look at your payer mix. You need to look at your finances and realistically think, what am I going to do to cover this gap for as long as it takes Congress to make up its mind? Now, I have heard from some larger institutions in the state, and I'm not calling you out, who have said, oh, we're just stopping all telehealth. That's it, we're done. This is the end of telehealth as we know it, no more. We're going to see everyone in the office. Don't do that.
Yeah.
Be reasoned, be measured, but think about the financial impact and the interpersonal impact, because we are taking the way we've provided health care for as long as most people can remember, at least temporarily turning it upside down.
Yeah, no, I agree. I think one of the big things to remember too is that, like I said already, your patients don't know why you're starting and stopping this, right? They're not sitting here following this policy as closely as you are. All they know is they've been able to get telehealth for however long, and now all of a sudden you're telling them that they can't. And that also causes a patient satisfaction issue. That causes a trust issue with your patients, okay? So that's why this messaging is gonna be really important for you guys. Your contingency plan doesn't have to be perfect, okay? It's probably gonna be really bumpy and it's gonna change a lot, but you at least need something in place so that you're not sitting here on September 30th still just holding out hope that something's gonna happen when everybody around you is telling you, hey, it's gonna happen. And trying to figure something out overnight for these patients who you're supposed to see the next day.
So our recommendation for you, if you don't have a contingency plan, is to actually go back to your office and at least assess the impact it's going to have on your practice. How many patients are going to be impacted? How many patients are currently getting telehealth that are Medicare patients, right? At least you have that number in mind. And then what's the financial impact? How much money do I have in reserve right now where I can keep paying the bills and keep seeing these patients? And is there a cutoff where I can't not bill for more than a week or 2 weeks or 3 months or 6 months, however long this is going to last? Because there are a number of things in terms of your contingency planning. These are like the big options, right? You can just continue to offer telehealth to patients without reimbursement. You're going to assume financial risk in case Congress doesn't retroactively, allow billing. And you could do that. You could just say, like, we're just going to keep offering services to our patients because we think that's the right thing to do. It's the best thing for our patients, and we're just going to suck up the financial risk.
And bill later.
Right, and bill later.
Hold your claims.
Yes, hold your claims and
Hold my claims and bill after whatever happens, right? You can allow your existing appointments, telehealth appointments, to proceed, but not create new ones, right? So you could just say for the patients who already have a telehealth appointment, we're just going to keep seeing them, but let them know after that visit that, we're cutting off telehealth visits, but we're not going to schedule new telehealth appointments with new patients, okay? That is an option. You can set a cutoff date where you say, after this date, we're no longer taking telehealth appointments unless Congress acts, right? But that really goes back to your financial risk. How much can you assume? How much are you willing to assume? And the trust relationship with your patients. If you don't have a communication plan and you're not going to have a solid one for 2 weeks, when the cliff hits next week, it might be smarter on your end to say, all right, we're not going to mess with anything up until we have a communication plan in place and we can get that out to our patients. So that is also a legit option when feasible. Then there are some that are going to say, we're going to just cancel all telehealth appointments after October, or starting October 1st. And so we're going to start making phone calls next week and say, sorry, we know this is happening and we're going to need to cancel that. You're going to need to come in. So those are a lot of options, and you're really going to need to weigh what's going to work best for your organization.
And there's really no right or wrong answer there. Okay, the only wrong answer is doing nothing, in my opinion. So pick whatever you want, but it's going to be different for each of you depending on, like we've said, your financial risk, what you can and can't handle, operationally what you can and can't handle. So don't think that because you chose option A and somebody else chose option C, that's necessarily wrong. You just need to choose something.
What have you heard from, I guess you've probably talked to some RHCs and FQHCs who are doing some of this contingency planning. What have you heard from them?
Yeah, so for RHCs and FQHCs, this actually, I think, is going to be somewhat less of an issue, just because there aren't a ton of RHCs and FQHCs. Like the adoption rate in terms of telehealth after COVID, it was really, really high, right, in 2020, because we had to have some way to see our patients. And then what we've seen is it's just kind of dipped significantly since then. And part of that has to do with the payment disparities that we've seen between a telehealth visit and if you were to do an in-person visit, right? So a lot of the RHCs especially that I work with, weren't really doing telehealth anyway. They were kind of doing it as a final option if that patient didn't have anything else they could do. But for those who do have contingency plans in place, they've basically made the decision to say, as of this date, we're not going to schedule any new telehealth appointments, right? Because for the last year, some of these people have been scheduling follow-up visits, for several months. And so as of October 1st, they're saying, hey, we're not going to schedule anything new. If it was already on the schedule, we're still going to see them in hopes that something will happen. Again, if it doesn't, it doesn't. But again, that also is going to be dependent on each RHC. Most of these RHCs are largely Medicaid-based. Right? So they don't have as many Medicare patients that they're having to worry about having to hold a ton of claims for them. So that answer would be different for an RHC or FQHC with a large Medicare population, excuse me.
So speaking of Medicaid and Medicare populations, what happens with dual eligibles?
that's going to be a tough issue. I think that a lot of companies and folks I'm talking to are saying, well, they're dual eligible. We're just going to make Medicaid their primary, Medicare secondary. Probably Kentucky Medicaid, which identifies as the payer of last resort, is not excited about that. I think I would use caution, flipping eligibility. Some providers are saying we're going to give them ABNs, advanced beneficiary notices. They're going to sign and say, I know my Medicare might not cover this. I'm accepting responsibility, but hoping my other insurance as a secondary payer picks it up. I really would use caution with that. I don't love an ABN in Medicaid space ever for any reason. I have never seen Kentucky Medicaid or an MCO be thrilled about an ABN used on a Medicaid patient. Often, and not to cast any aspersions, but this group can include people who maybe don't even understand what they're signing if they're signing an ABN. I'm from Louisa, Kentucky, small town. And if you hand the general population your typical CMS ABN, they could not understand it because that's not necessarily the level they're reading. And so I would not use ABNs. I would use alternate methods. If you have a Medicare patient, no secondary payer, and they want to self-pay, an ABN is fine. But I wouldn't use an ABN to try and bump that coverage to Medicaid or anything else. I would appeal when Medicare denied. I'm the queen of appeal every denial. So I would appeal and say Medicare denied because of Congress, and so we think the secondary should pick up. But I wouldn't rely on an ABN or just getting my billing system to flip-flop who's primary in that case.
So for those of you who don't know what an ABN is, it's a very legal notice that says, we're letting you know that your payer is not covering for this particular service. So if you want this service, you are bearing the financial risk of paying for the service out of pocket. And so when Anna said, you could do an ABN for Medicare if we're not dealing with the dual beneficiary things, that is a possibility, right? You could say, Medicare is no longer covering for telehealth services. Here's the ABN notifying you officially that telehealth services are not going to be covered. It might be temporary, but it's not going to be covered. If you choose to do telehealth services, if you sign this and you choose to do this, then you are basically saying, I'm willing to self-pay for this service. And there are going to be a subset of patients who would probably be willing to self-pay for that service for the convenience of not having to drive in. So that is an option that you can think about for that subset of patients.
And if you're doing that, don't make up your own ABN. CMS has lovely examples. Just, add your name. It has to be very specific and you can get in big trouble.
All right, before we move on from this whole Medicare telehealth thing, I thought we could just open it up for questions. Do you have questions for us about this before we move on to Medicaid and some of the other state policies? Question back there.
All the way in the back.
All the way in the back.
Keep your hand up, right?
Well, I had a question and a statement. Recently, I was told by my consultant that United Healthcare Medicare has stopped paying for audio only. They won't pay the audio only code anymore. The question I had was with the CMS thing and them not renewing the things they need to, what are our Medicare Advantage plans saying they're going to do? Are they going to continue business as usual, or are they going to stop?
In my experience, Medicare Advantage plans aren't great at paying for many things, so probably not. Sorry if any of you are in here, but you needed to hear it. But I would say that if you see Medicare stop providing a service, you might start to see other payers consider doing the same thing. Even commercial payers who historically that's been kind of safe. So I would say you need to proceed with caution there. I think it's worth reaching out to your Medicare Advantage plan, whoever your reps are, to say, hey, what's the impact going to be to us if Medicare doesn't renew this? Because you need to know that too, because chances are your percentage of your Medicare Advantage plan patients is pretty high for your total Medicare payer mix.
Yeah, managed care Medicare is not bound by the same rules as fee-for-service Medicare, but they tend to follow where Medicare goes. But in theory, managed care can do a whole lot more with telehealth than Medicare fee-for-service. It's up to them and it's up to their contract. So you can put some pressure on them and make the case of why it's important and why it costs them less to continue with telehealth and even add more than fee-for-service.
Yeah.
But that's really on you to work on them, and so that when they renew their contract, they can put more stuff in there.
Yeah, you truly have to be like a lawyer going to court to explain to them like what the benefit of this is. So have some strong thoughts when you share it.
And they may be prematurely denying. I mean, nobody should be denying now.
Yeah, nobody should.
And so appeal that and make sure it wasn't a denial and error. And if they jump the gun, your contract should still allow coverage and they should still have to
Yeah,
pay.
read your contract language. If it's in there, they need to pay for it until the contract year ends and you renew it.
Yeah.
Does the audio only change impact for behavioral health services too?
No.
No. So that's kind of already been in there since 2022. They've kind of had this audio only
Stays carved out.
statement.
Yeah, stays carved out.
And then my second question was, I'm in FQHC, the med management treatment for behavioral health services, if it's completed by a psychiatrist or psychiatric nurse practitioner, but it's a 99213,
Doesn't matter. It's still a 99213. It's not a mental health service.
not a mental health service by a psychiatrist.
Yeah, you have to pull that code list and look
correct.
at how you're doing this. And people are being a little bit creative with that and saying, well, if we get to that situation, maybe we'll provide some med management free when they do their telehealth visit and not billing at all for the med management.
Yeah.
It's what the provider thinks is appropriate for that patient rather than just skipping med management entirely.
Right. Any other questions pertaining to Medicare and the cliff? Seeing none. Let's move to Medicaid and Kentucky policies. So Anna, let's go back to you. What changes have you seen at the state level that give you hope or that concern you?
What gives me hope and concerns me is often the same thing. We have a legislature in Kentucky that is not made up of a lot of medical or mental health professionals. I still remember when we passed one of the early telehealth bills, and Dr. Alvarado, who was a state senator then, had to get up and explain how telehealth worked, because the serious question from a legislator was, is it like a robot that's going to travel around to people's homes and see them? And that was a completely authentic, straight question. So the level of understanding is not great. This is why we get healthcare bills each year that we read about in the paper and think, what on earth, where did that come from? But the legislature has put the Medicaid Oversight Advisory Board, acronym MOAB. I think I would have done better with an acronym. And their purpose is to hear from people. We are not leveraging that enough. My hope is that providers will start attending those meetings, and I think you can attend even virtually via telehealth, and telling them at the end in the comment portion, this is a concern we have in Medicaid. So my hope is that team and some community voices will keep Kentucky healthcare, particularly telehealth, on track. My concern, and another thing that's working really well is more of the MCOs and commercial payers are starting bundled services. They say, okay, this is the sum we're going to pay you to treat this patient for this condition. If you're very detailed, number oriented, you're going to lose money on those initially because you make more without the bundle. But for those of us who want more flexibility, the bundling really essentially says if the provider and patient thinks it's right for them, here's your bundled payment, go to it. And that makes me hopeful. The state level concerns are eventually, as Medicare goes, often so does Medicaid. Particularly if it's cheaper for them to change their ways. And so we need to really look at the denials we're getting from Medicaid and MCOs and commercial payers to see if there is some sort of a pattern. I'm already seeing a lot more enforcement of care limits. We've seen Humana take behavioral health units of care from 200 to 4. We're seeing a lot of that shrinking. We're seeing a lot more hardcore negotiating when it comes to telehealth reimbursement. We have parity, but parity is modified by the state contracts that say, but they can negotiate with you to make it cheaper. Anyone who's tried to negotiate with an MCO knows, good luck to you, right? Those are contracts of adhesion. And so we're seeing them try and save money in various ways. I really genuinely do not anticipate in my lifetime them looking at telehealth and saying, we're going to cut costs by doing away with telehealth. Yeah. But I think we're going to see a lot more strict enforcement of units, of coding. In the behavioral health space, a lot of people need to read their CPT code definitions a little more stringently because there's a lot more enforcement when you're providing something in a group and the code says this is an individual service. I had a provider tell me yesterday, it is individual, Anna. All 8 of them I'm addressing individually. No, sorry, Bobby, that's not working. So I think there's going to be a lot more cost-saving aggression on the Medicaid side, a lot more enforcement and audits. But we're going to keep telehealth. I really remain convinced. Medicaid loves telehealth. Commercial payers love telehealth. In the commercial space, I am seeing them do some of these cuts and then say, but you can still have all the telehealth you want. You just use our in-house team. Yeah. And so that's going to be their workaround. I don't anticipate Medicaid getting an in-house team. No.
So Amanda, from a state level perspective, how do you see FQHCs and RHCs doing in Kentucky and compared to other states and compared to, are we better positioned here?
I think in Kentucky we are better positioned just because, as Anna said, Medicaid is pretty telehealth friendly, and so we can get paid the same as an in-person visit for RHCs and FQHCs. So you can have a RAP eligible service that you're providing in those spaces. So I do think we are, and because of Medicaid expansion, a lot of these are with these MCO plans. And so I think we're pretty well positioned here, and I don't see anything really changing about that.
All right. Do we have any questions that are specific to state Medicaid or private payers that we want to ask before we wrap up?
It's hard to believe that Medicaid is the favorite here instead of Medicare. That's not how I thought this was going to go.
I wish someone from Medicaid was here to stand up and sort of take a bow.
Yes, I gave you a compliment.
Yeah. No questions about Medicaid or state? So there are a bunch of things that we did not address here at the policy level, like the licensure issue and prescribing issue. What we did do was created a document, so I wanted to call your attention to this. In your app, it's under resources, I think, the general resources. Some of you may have picked up a hard copy when you walked in. The hard copy is not as useful because it doesn't have the clickable links.
So by all means, type it right in there.
But you can Google it if you want. But if you go to the copy that's in your app and just download that, it's then you can open it up and click on the links. They are resources for all sorts of policies, right? So we have reimbursement policies. There is a blog site about the telehealth cliff that the Telehealth Resource Center's put together that has a lot more on the contingency planning. So if you're one of those that didn't raise your hand that you have a contingency plan, you might want to click on that to really look at things about communicating with patients and communicating with staff and what some of those contingency planning pieces would involve. We also have a ton of things related to Kentucky-specific documents, so like Kentucky Medicaid, and what are the parameters there. So please make use of that document because there's a lot there. So as we wrap up today, I wanted to ask one last question to both of you. What is one powerful thing that providers or anyone in this room can do to shape the future of telehealth? So, Amanda, let's start with you.
I think you need to be an active participant in advocacy efforts towards telehealth. Raise your hand if you have ever contacted a legislator about telehealth. Oh, good job. Keep doing it, okay? If you've done it once is great. 2 and 3 and 4 and 5 times is better. You have to kind of be like that really irritating gnat that they just want to swat away, right? Because you keep coming back, okay? In the resource that Kathy just talked about, if you're an RHC or an FQHC, and actually it doesn't matter if you're an RHC or an FQHC, you can be anyone. There is something under the National Association of Rural Health Clinics. There's a link on there that will take you to something that's called a voter voice campaign. And this is basically an online platform that is hosted by NARHC. You can go out there, you can click on it. They have a whole host of different advocacy campaigns geared towards telehealth, but towards other things impacting, rural health as well. But you can go out there, you can click on those. It's going to pre-populate a message for you. So you have no excuse. You can't say, well, I didn't know what to say because they've already populated it for you. Oh, well, I don't know how to contact. Guess what? All you have to do is put in your address and it's going to send it directly to all of your legislators and tell them, hey, this is what telehealth, the telehealth cliff and telehealth going away. This is how this impacts our clinic. Obviously, I would encourage you to put personal stories in there of patients that you know who only utilize telehealth for their care, okay? Maybe you have a provider that you hired solely to do telehealth, okay? That would obviously impact them too. So I do encourage you to do that. But if you're not going to be an active participant in advocacy, then when these things happen, you can't complain about what happens, okay? So take back your own power and do something about it.
Anna, what would you like?
Oh, mine is along the same lines, particularly if you're in Frankfort or Lexington or an easy drive to Frankfort. We really need to see more providers of all types at the Capitol because everyone has an advocacy group and it's very easy to say, well, the Kentucky Board of Nursing is advocating for me. The counselors are advocating for me. But it's important to go to look at your state legislator in the eye and say, hello, ma'am, this is why I do telehealth and this is why your community, the city you live in, needs telehealth to continue. Kentucky Medicaid can't necessarily influence CMS, but legislators at all levels meet and mingle. And so if you get your legislator from Murray, Kentucky sold on telehealth, that person will ultimately talk to your federal representative and weigh in. It's important to write to your local folks, not just at the federal level, but at the state level. And as importantly, it's important to reach out to the cabinet. We had somebody brave earlier asked Dr. Langfeld, well, what about the state telehealth website? It hasn't been amended. It hasn't been amended since 2023. And a lot of things have changed since 2023. It's fair to ask the cabinet when you're in meetings with Medicaid or OIG or public health or anyone, why is that? Why are you not informing us what's going on and how we can impact that? Because if we don't hold the people who hold the purse strings accountable, we're just letting our practice flow through our fingers. And you can reach out on your own behalf. You don't have to be a lobbyist. I tell people the most important thing I learned when I came to Frankfort, because I used to think that laws were made by learned people sitting in rooms with tomes and advisors. Laws are made because someone walks up to their rep in Kroger and says, man, I hate the price of carrots. Why don't you fix that? And that rep goes to Frankfort and says, I also hate the price of carrots. Let's subsidize carrots. That's how we change laws. It's that simple. So we all have the power to ask. So ask the cabinet, ask your legislators, ask your local officials to support what you do, and more importantly, what your patients need.
Sorry, we've killed all the
I'm killing the Grab that one. So I will talk louder, but yes, what Amanda was saying was advocacy. We need to stand up and speak out.
That one's good too.
So on that note,
We're done. It's telling us
Yeah.
we're done.
No worries.
so please join me for thanking our panelists. We are done.